is Dr. Anchal.
Good afternoon, everyone. Today, I will be sharing a study on comparison of bang versus goniotomy in PCG eyes. So, as we all know, PCG is a primary developmental anomaly of the trabecular meshwork, and the mainstay of treatment is surgical intervention. And the corneal clarity mostly determines the type of surgery. When the cornea is clear and the angle is visible, we go through with ab interno procedures such as goniotomy, and when the angle is not visible, then we go for ab externo procedures. So goniotomy was the first angle surgery described by Barkan, as we all know, and it enhances the aqueous humor outflow by incising the trabecular meshwork. And the surgical success at 1 year stands about 60 to 80% across studies. And BANG stands for bent ab interno needle goniectomy, which is a variation of Barkan's technique given by Shute, and it uses bent 25 gauge needle in reverse cystotome fashion. It excises the trabecular meshwork instead. So we thought, will the stripping of trabecular meshwork offer any additional benefit over simply incising the tissue in infantile PCG eyes? For this, we did a study to evaluate the efficacy of BANG compared to the established standard of traditional goniotomy. Our study was a prospective, interventional, parallel group randomized control trial in which we included all infants with bilateral symmetrical PCG with an onset between 1 month to 1 year of age with no prior history of ocular surgery and a corneal clarity grading of less than 2. One eye of each infant was randomly assigned either goniotomy or BANG in a 1:1 allocation. This was computer generated randomization. Our outcome measures were intraocular pressure control and the requirement of anti-glaucoma medications, and the secondary outcome measures were complications of surgery and the requirement of additional surgery. Complete success was documented if intraocular pressure was less than 18 millimeters of mercury without medication, and if up to 2 medications were used, it was determined as qualified success. If more than 2 medications were required, it was noted as a failure, or also if there was a need for resurgery. So we were able to recruit 8 babies, and one eye of each was randomized into goniotomy and BANG, and all of them were similar in all such following characteristics such as corneal diameter, mean corneal clarity grade, axial length, intraocular pressure, Cubdis ratio, central corneal thickness, baseline number of medications, and the mean degrees of angle treated. Outcomes were evaluated at 3 months, 6 months, and 1 year. And we can see that at the preoperative phase, intraocular pressure in the goniotomy and BANG group were 24 and 25.5 respectively, and by the end of 1 year, it had decreased to 15.3 and 17.1 respectively. But there was no difference between both the groups at any point of time. The number of anti-glaucoma medications was similar in the preoperative phase. It was 1.7 in goniotomy and 2 in the BANG group, and by the end of 1 year, it had decreased to 1.14 and 1.28 respectively. Also, there was no difference between the groups at any point of time again. This graph summarizes the entire study. The line diagrams above are showing the degrees of angle treated in both the eyes of each patient, and we can see that the extent of angle treated was similar in both the eyes of each patient. And the vertical bars with the lines are showing the preoperative and 1 year IOP of the goniotomy group, and the bars with the dots are denoting the IOP of the BANG group preoperatively and at 1 year. So in the goniotomy group, 3 eyes were medication free at 1 year, 4 were qualified success, and 1 had failed. In the BANG group, 2 eyes were medication free at 1 year, 4 were qualified success, and 2 had failed. Hyphema was the only complication noted. In the goniotomy group, 2 eyes had hyphema, which resolved within 2 weeks, and in the BANG group, 3 eyes had hyphema, which resolved again within 2 weeks. So we could conclude that the outcome was comparable between both the groups, and the added complexity of excising trabecular meshwork in BANG was not conferring any additional benefit in PCG eyes. So the IOP lowering effect could be attributed to the angle widening and falling back of the highly inserted peripheral iris, regardless of the amount of trabecular meshwork tissue removed. Our study is limited by small sample size, but it has a very stringent study design. And the goniotomy still remains a reasonable surgical procedure in PCG eyes. Thank you.
Hi. Lovely paper. Of course, it's
Thank you
been
so much,
published as well.
Yes, ma'am.
I have one question. How often do you do EUAs to capture complications of procedures like this for
Ma'am,
babies?
a standard 2 to 3 month follow-up EUA is done in all because we have to remove the suture
No, I
anyways.
want week 1, week 2. What do you do? Give me the protocol.
Okay, ma'am. So there's a POD1 follow-up in which
Okay.
we note on a torchlight, if the baby is very small, then we have to do a torchlight examination.
Yeah.
We look for hyphema,
Yeah.
we look for corneal clarity if it is improved clinically, and we monitor the IOP on eye care rebound tonometry.
Okay.
And if there is any other complication such as very low IOP, then we may go ahead with the ultrasound. We may plan for an ultrasound for posterior segment evaluation on the coming next week follow-up.
Okay.
And then we have a POD5 follow-up in
Okay.
which we repeat the same procedure, and in case of doubt we go through with an ultrasound, and then at 1 month we have another follow-up in which we plan for a PAC and a repeat EUA for the next visit.
So the first EUA after surgery is 1 month.
2 months.
2 months.
2 months. 2 to 3 months.
So is there a chance that you're underreporting complications?
Ma'am, hyphema is visible clinically.
May not be visible clinically.
Okay, ma'am.
On
But then
torchlight?
yes,
On
ma'am.
torchlight?
On torchlight.
Yeah, may not be visible.
But then, ma'am, it might be so less, then it's going to resolve only if it's not visible and the IOP is all right.
Okay. Thank you.